really for your benefit, so that you know like what you're missing. Basically, you can see your strengths and the weaknesses, and you can do something about them. But this isn't. It's not our assessment of you. Okay, it's your assessment of you. If you don't do them, I think you're going to miss out. But I don't think anybody's going to fine you for not doing them. Okay.
Does module 1 end after this week and we are starting module 2 next week, or will next week still be module 1?
I can't remember, David. Have you got it?
Hmm?
I haven't got it in front of me. Do you have it?
Oh, Jim, it really depends. What do you plan on doing today, Jim?
I'm going to go over bias and error correction.
So module 2
general
next week.
examination scheme. I'm thinking that I've actually got 2 more sessions on this part of the clinical reasoning.
Mhm.
So this one and next week. But I'm thinking about what videos are on there. If I've got it, I can get it. Let me have a look.
Yeah, I'll sort it for you guys. But this week we're going to do, it sounds like Jim has 2 more along this series. And then we'll probably shift gears.
But I think there's more videos yet on the lumbar spine, isn't there? Because that was the lumbar spine class came in really early.
Mhm.
We didn't have the normal month or 5 weeks build up to the class for what reason or another. So there a few of them I think were behind that. So we've extended the period behind the class because we lost the period at the front of the class, as far as videos are concerned. I haven't got it in front of me. You'll see when the videos come out. There'll be, if the labels on it refer to the lumbar spine, you're still getting lumbar stuff. Okay.
Got it, thanks.
Okay, let me share screen here. Dave, can I get screen sharing?
Yeah, sure. Oh, let's see if I can do that.
Dave, you got a couple of minutes after the meeting?
Me, I do not.
Okay, let's set up something.
Okay. Yeah, let me see about sharing screen here. I'm on my iPad, and my iPad options are different than my computer options, and share screen is not one of my designated options. So I keep talking, Jim, while I push buttons and try and fiddle my way through this.
You want me to send it to you?
No, yes, if you can email it to me.
Okay, it's a pain in the ass. This is power.
It is a pain in the ass. Let me see if I can go ahead and start talking. What I'm gonna do is try to open up on my other computer and see if I can get another link going.
All right, okay, then let's ask the usual questions. What questions do you have or comments on the videos you've looked at? No?
Hey, Jim, could you talk a little bit more about the video with reflex inhibition and segmental facilitation?
Yeah.
We talked a lot about it in class, at least for segmental facilitation in class. Could you, I mean, I guess I just don't quite understand exactly what it is. I think I have a rough idea, but I guess what it is and then how it relates to what we're treating, I guess is my other question.
That's a good question. First off, you're getting this really early just to introduce you to it, and it is an introduction. This becomes a lot more important later on, much more important. But they're both neurophysiological phenomenon caused by, in the case of segmental facilitation, really nociceptive input, prolonged nociceptive input. And it's a form of central sensitization that seems to be occurring in the spinal cord. So with prolonged, Alex, you'll get more on this later on, but I don't want to get into it. Just assume it's nociception for the moment, it makes the whole thing easier. Prolonged nociception sensitizes the segment into which the nociception is going. So let's say you've got tennis elbow, that's going into predominantly C6. So C6 will get hyperexcited. And that's really what it is. Facilitation means to make easy. So you get hyperexcitability of that segment. So the response of the segment is higher than it would be normally. So you get increased muscle tone. You get increased sensitivity, so palpation can be tender. You get neuromuscular incoordination because of the input messing up the output. So you get weakness from it. But it's all neurophysiological. It's not a diagnosis, it's an effect of the problem. Okay, so as far as that affecting the diagnosis is concerned, mostly what it will do is confuse the diagnosis. So once you allow for that a little bit, then it really doesn't play a role in diagnosis. What it plays a big role in is etiology. So we're giving you this now so that you don't get too much when we start talking about etiologies. So it's a fairly brief introduction to this. Okay, but as a diagnostic issue, it's not that important. But you can understand why, let's say tennis elbow, you've got pain in the lateral elbow, and you palpate the common extensor tendon, and that's tender. That may be because of a tendinopathy, or it may simply be because of segmental facilitation, making those tissues more tender. Does that make sense?
Yeah, that makes more sense. And I guess kind of my thought too with that would be then is that must play into like movement patterns and, you know, like the motor retraining and stuff like that, correct? Where, you know, the etiology becomes the issue with that.
Well, yeah.
Yes.
Okay, well, let's look at tennis elbow. Segmental facilitation can be the etiology of a tendinopathy, tennis elbow, by weakening the muscle. So if you have prolonged segmental facilitation, the extensor wrist muscles become weak, and it makes that tendon vulnerable to what should be routine stresses. So this can be a direct or a contributing factor to a tennis elbow, degenerative tennis elbow. So as I say, this idea, the concept of facilitation is much, much more important in etiology than it is in diagnosis. Mostly what it will do with diagnosis is confuse it, but it doesn't play a direct role in making the diagnosis. Now, as far as retraining patterns are concerned, this is one of the reasons you don't try and retrain a pattern until you get rid of the dysfunction that was causing the malpattern. And actually, if you get rid of the dysfunction and the nociception and the proprioceptive mess, the pattern comes back very quickly. This is not a neurological disease. So you haven't got the same problems that a neurotherapist would have. So the pattern comes back very quickly, and your retraining is almost cursory, usually. Okay, but it is important when you're dealing with the etiologies. Reflex inhibition is not the direct opposite of segmental facilitation, but it almost is. So reflex inhibition is caused by inadequate proprioception. And that can be from hypomobility, hypermobility, instability, any of the biomechanical dysfunctions we deal with, and a few other things as well. But what you get now is weakness and decreased tone. So this can also be an etiology. In fact, again, its major function with, as far as we're concerned, is sorting out etiologies rather than diagnosis again. Is that okay? So the segmental facilitation is going to be distributed along the segment, the whole segment's involved. So you can see hypertonicity, non-fatigable, non-breaking weakness, trophic changes, trophodema, scratch reflex loss, so you lose a hyperemia of a scratch reflex and so on. A little bit of increased briskness in the reflex sometimes, whereas reflex inhibition is local to the joint over which the muscle is passing. And you'll see it's patterned weakness, but it usually is in a PNF pattern. Now, they can both be improved by the same thing. You can temporarily improve both by inputting proprioception. So proprioception has a direct influence on reflex inhibition because it equalizes the proprioception and makes it more normal, whereas with segmental facilitation, it mediates the nociception and decreases the facilitation that way. Is that okay?
Yes, thank you. That makes more sense.
Don't get too caught up on it right now. This was very introductory. It becomes much more important in the last four modules.
Yeah, what you really want to do is, it's hard to show muscle testing, reflexes, and to do all that in lower extremity without giving a little bit of this.
Reference.
then Because then it's like radiculopathy, no radiculopathy. Then you're in the weakness, but you don't know why. So like we used to not put this into the later modules, but we felt like, okay, it's a little more painful to put it in now, but you really see the value in a good exam when we go through the myotome reflexes and why we put so much time into it.
All right, but don't get overly worried about it. You're going to get a lot of this, for good or bad.
Look for it is what you want to do. See if you can identify the patterns of weakness. Is it reflexive? Do I think it's segmental? And we went back up and palpated multifidi. Can you find the multifidi inhibition potentially maybe associated with this?
Yeah, that's a good point. Practice now.
Yeah, and look for the patterns. Because we saw it in clinic. We saw that we could see the multifidi patterns in clinics. I mean, look how, was it Kevin who looked so good the first day versus the last day?
Okay, anything else on the videos?
I have a question, Jam.
You could tell me that to just wait, but if you can go over the naming and the naming of the like PIVM and PAVMs, I'm just still struggling with like what you're seeing on one side versus the other. And I'm gonna watch the video again, so you can tell me to wait also.
What are we talking about? Sorry.
Just clarifying PIVM and PAVMs again. What is the passive physiological intervertebral?
I'm just wondering why you're talking about one side versus the other side.
Yes.
Okay.
Okay, well, a PPIVM is a passive physiological intervertebral movement, whether it's active or passive. Strictly speaking, that's a PPIVM. So that would be usually, no, it's passive, sorry. So it would be flexion, extension, rotation, side flexion. Combinations of movements, side bending, rotation, extension. Any physiological movement done passively between vertebrae is an PPIVM, P-PIVM. Okay, a PAVM are the glides at the joints. So these are passive arthrokinematic intervertebral movements. So these are the joint glides. So for flexion, for example, at the facets, it would be a superior glide. For extension, an inferior glide. Right side flexion, you'd have an inferior glide on the right side, a superior glide on the left side. For rotation, it will depend on how it couples with side bending. But if left rotation couples with left side flexion, you'll have extension on the left side and an inferior glide on the left side and a superior glide on the right side. So you're giving movement names to PPIVMs, flexion, extension, so on, abduction, and so on. Whereas for the glides, you're giving directional descriptions, up, down, superior, inferior, and so on. The glide is definitive. All right, the PPIVM's not. The PPIVM will tell you whether you have hypermobility or hypomobility or normal on a good day. It won't tell you whether it's an articular problem or an extra-articular problem, such as tight muscle. The PAVM, though, will tell you that. If the PAVM is positive, that is, it's restricted, then it's an articular problem. If the PAVMs are normal, but the PPIVM is restricted, that's an extra-articular problem. Is that okay? That was pretty quick, but was it okay, or do you want it again slower and different?
Yes. Okay. I think, and then so a lot of my confusion comes from, so if you're palpating and it's more posterior on your right, and now so if it's more posterior on your right, now you're gonna give some pressure and see if it moves. So if it moves, it's a hypermobility on the right.
No, hang on, I see where you're going. That's why I was wondering.
That's where I'm confused.
You're actually talking about position testing through PPIVM through
Okay.
PAVM. Yeah. So your position test says it's posterior on the left, inflection. All right. Is that okay?
Yeah, yep.
Okay. So one hypothesis. I still can't get screen sharing, Dave.
It should be, oh, sorry, it should be there.
So one hypothesis is that when you try to flex, the right side flexes and moves forward, the left side stays back. So it's posterior compared to the right side. Is that okay?
Yes.
Okay, so that's your first hypothesis. You test that hypothesis by doing a PPIVM, which is a PA on that left transverse process. So you're swinging it around to the right. Now, if it can rotate to the right in flexion, it's not hypomobile. Is that okay?
Yep.
That means you now move on to the second hypothesis that the right side is hypermobile. That is, when you flex, the right side, both go forward, but the right side goes further and it leaves the left one behind, but that's where it should be. But the right one's moving too much. Is that okay?
Yes, that helps. Thank you.
Now what you do is you push the right one to see what the end fill is on that. If that's normal, then you have both sides are doing flexion normally. So your third hypothesis, which you can't test, is that you have a congenital anomaly, or it's a positional fault compensating for something else. But there's no movement dysfunction at the left or right joints into flexion.
Okay,
Right?
that's helpful.
Now, if you found
Because this is almost
left-
exactly how Jim describes it in his video.
Yeah,
in your manual.
I don't mind doing it twice. So if the left side can't go forward, your next question is, your next hypothesis is that this is an articular problem. And you test the hypothesis by doing the joint glide. So now instead of pushing it forward, straight PA, which was your PPIVM, you now push it supra-anteriorly, which is the direction of the glide. If the glide can't move, then it's an articular hypomobility. If the glide does move, but the PPIVM is limited, that's an extra articular hypomobility.
Jim, say that last part one more time, please.
How's that?
The extra articular hypermobility or hypomobility.
Hypo.
Yeah, that's what she wanted you to explain, I believe.
Yeah. There is no glide for hypermobility, not technically speaking. You can do a glide if you find that gliding is an easier thing to do. That should show up as hypermobile. But if a joint's hypermobile, sorry, if the bone is hypermobile, then the joint must be as well. So you don't have to test that.
Okay.
Okay?
I'll
Don't
keep
get
watching
worried
the
about
video.
asking these questions. This is, these terms are not familiar to you. I doubt very much whether anybody's gone into much detail about biomechanical dysfunction before. Don't worry about it. We'll keep repeating it as long as we have to.
Mm-hmm.
It's a lot easier for us to repeat information than make up new information, believe me. Saves us studying.
Oh, yeah, that's true. Good point.
Okay, anything else there?
Jim, we did discuss about multifidi inhibition, reasons for that. You know, it might be good just to kind of go over, you know, when you're looking at how to palpate multifidi,
Yeah.
what are you looking for when you're expecting that you're going to have some inhibition at that segment?
Okay, well, when you're palpating multifidus, you're either looking for increased bulk or decreased bulk.
Mm-hmm.
Or normal. So if it's decreased bulk, that would imply it's either atrophied or hypotonic. If it's hypotonic, then it's caused by reflex inhibition. Now, the reflex inhibition isn't coming from the segment per se, it's coming from a dysfunction of the segment. So this isn't sensitization. This is lack of proprioception from the segment. So usually the facet joint. So the facet joint's hypomobile or hypermobile, or it's unstable. This will lead to reduced proprioception, which can then lead to reflex inhibition and hypotonicity. Atrophy of the muscle is either caused by neurological problems, a disc herniation, for example, causing a radiculopathy. That's going to cause a lot of atrophy of the multifidus because this is a key muscle. It's innervated almost entirely from that segment. So you're going to lose a lot of tone and a lot of muscle mass. Or that atrophy is the result of prolonged reflex inhibition, and they do become atrophied. MRI studies have shown that you can lose up to 50% of the muscle bulk from reflex inhibition. Okay, so if you find decreased bulk, it can either be atrophy or hypotonicity or a mixture of both. It's either indicating a neurological problem, radiculopathy, for example, or reflex inhibition that's gone too far, as it were. If you find increased bulk, that's hypertonicity. That indicates segmental facilitation. Now, if you go over that with a scratch reflex, if it's segmental facilitation, you should find a diminution of the hyperemia over that segment. If it's reflex inhibition, it doesn't have much effect, if any. And that loss of hyperemia is due to vasotone, increased vasotone, presumably.
So yeah, that's exactly the scratch test is. You scratch along, remember that paraspinous process border. And again, you'll find the 3 or 4 segments above it. You create a red line on their back. You get to that one segment and you basically it's blanched, it's white. And then the red line picks up after the segment for the traditional scratch test. I tend to use it more in the cervical spine, it seems like, but that's just always been my habit or bias versus lumbar spine. But I could probably look at more in the lumbar spine.
I like the scratch reflex because it's very sensitive, I think. You've got to be quick. Sometimes that fading is very quick. Because, like if you scratch it, it occurs and then it disappears. Or you'll see it's wider, the scratch is wider until you hit that segment, then it narrows in and it widens out again. So it's not always an absence of it, but it's decreased. I find it very sensitive. So that's usually the first test I do if I've got land in the stomach anyway, whether it's lumbar, thorax or neck, because I think it's very sensitive. But it's the first real indication for me that this is segmental facilitation. If I haven't done strength testing, if you do strength testing first, then your first indication is weakness. But the scratch test, if you're not sure about the weakness, whether it's segmental or whether it's fatigable or breaking, if you're not sure about that, the scratch reflex should settle the argument for you. It also gets a bit more complicated than that, and the scratch reflex test comes into its own in more complex cases. For example, if you've got a mixture of reflex inhibition local to the joint and segmental facilitation elsewhere, then you'll pick up braking weakness around the joint, you'll pick up non-braking weakness elsewhere in that segment, and you're going to get confused. The scratch reflex helps get rid of that confusion. So it's all interplay. Everything plays off everything else. It's really very nicely done. It's nicely integrated if you work it properly. It's a very nice, I was going to say diagnostic.
And we'll do the scratch test in module 2. We'll cover that too as well as in there. So you get a chance to see it, play with it. You can do it right now just by scratching your patients. Just let them know what you're doing first.
Yeah, and again, it's something you should concentrate like do because it can be subtle. You've got to be quick with it sometimes, and you've got to look for nuances. Is it as thick over that segment as it is elsewhere? Okay, so it's not just there's no blanching going on. If that happens, that's nice, but it's not always that simple.
Now, for some people,
did I answer your question? I can't remember if I did or not. Who asked? Oh, just talk about reflex inhibition. Anyway, yeah, as far as palpating bulk is concerned, increase or decrease bulk in the multifidus.
What would be, like we talked a bit about neutral zone there too. We kind of went over the different neutral zones and basically those end fields. Like with this, how do you view the neutral zone, the impact of an inhibited multifidi potentially, let's say the L5S1 on the right, if you have chronic inhibited multifidi?
I'm not sure you can test the neutral zone of the multifidus.
Well, the segmental stability, let's say. What do you do to the segmental stability, or do you expect to see? Because you're going to test that when you kind of look at the pivot and pavum.
I'm sorry, Dave, say that again.
Look, I'm wondering about the impact of inhibited multifidi on the spinal segment.
Yeah, well, that's considered the cause of segmental instability, the major cause of lumbar segmental instability. Because if you can't control the neutral zone, then basically that's a negative feedback, because you're not controlling the neutral zone, so you're getting proprioceptive loss, which will lead to more reflex inhibition going on. And eventually that neutral zone will start to be so large that you'll incur into the end zone. So the end zone tissues will start breaking down. In effect, Charcot joints. And that's when I would think it becomes symptomatic. I can't see neutral zone being a symptomatic issue. But as soon as the end zone tissues start to break down, that's when it can become symptomatic. I don't think it always does, but it can be that. So of course, it's a negative feedback loop. When they become nociceptive, then you start getting segmental facilitation, which weakens them further, and so on and so on and so on. So it's very much negative feedback.
So we have that expanded neutral zone or that laxing, you're not getting the proprioceptive input from the capsule or the structures because they're not reaching that point of tension and that increase in tension. So the lack of proprioception comes from that.
I think it may even be a bit more subtle than that. I think the neutral zone is where no tissues are being stressed. There's no stretch going on. It's a free zone where the ligaments are not engaged, the muscles are not engaged, and so on and so on and so on. Not very big in most joints. So when that zone starts to get bigger, you're getting more movement, but no feedback. And I think that plays into it as well. I think, like, if you look at the Australian description of this, which is a bit limited, but they'll turn around and say, okay, the neutral zone increases because of pain inhibition. So the patient hurts herself badly enough that a particular direction of movement becomes more painful and you're inhibited into moving into that range. Over time, that will lead to a loss of proprioception into that movement because you're not moving there. So even when the pain goes away, you've still got that reflex inhibition. As soon as the reflex inhibition kicks in, you then have that negative feedback loop that increases the neutral zone, that increases the neutral zone, that increases the neutral zone. And then the end zone structures start to get kicked about. That's typically the way I look at it. That's a bit limited because I think most of the stuff we see isn't that at all. I think most of the stuff we see is proximal hypomobilities stressing out the end zone structures first. So the Australian model goes from the outside in, trauma, pain inhibition, reflex inhibition, then the end zone structures. Proximal hypomobility stress the end zone structures, they break down, and that's where you get the proprioception loss from, which leads to reflex inhibition. Also, you've got nociception kicking in because the end zone structures are breaking down, and now you add on segmental facilitation to that, and you have this double whammy of weakness, and you lose control. And the multifidus is the primary problem with this one because this is what controls the translation, which is the neutral zone of what we're talking about. So if that translation increases its neutral zone, the segment becomes unstable. Not just the joint now, but the segment, not the facet, the segment.
We talked about in class, just to redefine, the neutral zone is that region that you move before you start to tighten any ligamentous structures, muscular structures. It's the free float in the sense of the joint before you start putting tension into those structures. We just talk about
the first thing you lose when that neutral zone increases, not the ligaments, it's muscle. The muscle isn't responding to that. And so you increase the proprioception loss because the muscle is not picking that up because the neutral zone is bigger than it should be, but it's still not big enough to really stimulate the muscle. So you get this negative feedback loop. I don't know that it's a model. I don't know if the exact mechanism has been fully established, but it's a model and the model works fine.
That's an idea of slipping. Like I did your rotational testing, putting it in the shortened position and then the lengthened position. So, okay, you can be weak when I have it flexed, but when we extended the individual and I went to go rotate them, I could break them each time.
Yeah.
When we did that rotation, I think it was Kevin, I did that on probably the first morning, and kind of explain that model to them of how that relates to what we just talked about.
Well, I think what we're looking at there is secondary inhibition. The primary inhibition is going to be the local stabilizers. We're talking about spine now. So the local inhibition is going to be multifidus, I don't know, iliopsoas, whatever you want. But these are the ones that directly control the glide. When you're testing when you're testing those movement patterns, and you find them weak, that's not the multifidus. These are the abdominals and the big extensors. So I think what may be happening is when you actually get them to the end of range and then apply a strong eccentric stress to it, the multifidus and the other stabilizers are not doing their job and it slips. And that kicks in the big muscles inhibition. But that's not primary inhibition. That's secondary inhibition. It's caused because it slips. And as it slips, these big muscles cut out. And that's what you see, that breaking, sudden break in those muscles. I think that's what's happening. But I've started to differentiate between primary and secondary inhibition. This gets confusing more in the shoulder than it is in the lumbar spine, because you can have this big breaking weakness. If you test up here and you push them down at these PNF patterns, it will suddenly give way. But if you do the test locally around the shoulder, the same test of abduction, lateral rotation, so you're pushing into, these are the muscles that are working, aren't they? You're pushing them down that way. If you test these in the neutral position in the same manner, they're stable. So the reason they're breaking when you're testing the full range, I think, is because the shoulder is inherently in an unstable position, and the local stabilizers, the rotator cuff and biceps, can't hold it. That slips, and then the big muscles give way. That could also come from the thorax, because I think you're seeing the same thing there. So if the thorax is unstable and you've got the arm right up there and you push it down and the thorax slips into the spinal joint there slips, then these muscles are going to cut out again, presumably inhibited by the segment. If there's no weakness around the shoulders, if the rotator cuff and these local tests down there are okay, but up here they're lost, I think you can probably say it's the thoracic spine that's causing the secondary reflex inhibition. If the muscles around the shoulders are weak in a more neutral position, then you have a primary reflex inhibition going on there as well. You can check this though by doing PAs on the thorax. So on the segment that you believe is unstable, you do PAs on that, that increases the proprioception, and now this one should be stronger. Unless you've got atrophy, then it doesn't work. But this one should be stronger, and these will stay the same if that's okay. If these are not okay, this one will be okay, this one will be stronger, and the shoulder muscles won't. So again, it's a matter of playing with what you're seeing. If you think it's a thorax, wobble the thorax. If you think it's a shoulder, wobble the shoulder. Trial and error. Is there anything else there, guys, on the videos? Or on that, actually. It's a complicated subject. And you can't deal with it in one video or in one session. As I say, this is going to prop up every single module after, including 4. So 4 onwards, this is going to be cropping up all the time.
My mother-in-law wanted to live there. She didn't want to come back to Fort Meade.
I was going to do some stuff on bias and error correction. You know what I'll do though? If you don't mind watching a bit more video, I'll narrate the PowerPoint presentations I was going to do, and I'll let you have them, Dave. You can let them have it.
Okay.
I hear Germany's another good one that people like travel to.
If you haven't got any more questions for me, I've got some for you.
Yeah.
Find them. There we go. This is a really quick, it's something you should try and do yourselves. Just give yourself some problems like this. So there's 6 questions down there. We'll go through as many of these as we can. But it shouldn't be that long. So what I want for each one of these, and we'll work through the first one together, give 3 differential diagnoses for each presentation and your negative differential diagnostics test to eliminate each one. Does that make sense?
Yeah. Jim, do you have it on the screen yet, or are you putting it up?
Oh, sorry, yeah. Did I not put sorry. I didn't put sharing on, did I? Got it? Thanks, Dave. Okay, so all right, so let's have a look at right low back pain and upper buttock pain in a 28-year-old. Now, straight off the top of your head, I'm going to change the rules a bit. Straight off the top of your head, what hypothesis are you going to investigate? Straight off the top of your head, just with that much information. All right. Write it down, commit to paper. And then let me have another 2 differentials for it. Okay. My guess is most of you came up with biomechanical dysfunction in the lumbar spine. Would I be correct in that? Who didn't say that? There's no right or wrong answer to this neither, by the way. You can't be wrong with this. So
I said
who
disc
didn't say a biomechanical dysfunction? Everybody? Now, okay, I'm going to assume everybody did. This is availability. It's not necessarily availability bias yet, but it's availability. The class you just did was on biomechanical dysfunctions for a large part. This is what's available to you. Okay, so perfectly reasonable one, biomechanical dysfunction. It only becomes a bias when you don't let it go. Okay, actually it is a bias, but it's a good bias. It's a heuristic. It's a shortcut. Nothing wrong with it as long as you're prepared to dump it. So what else have we got for differentials?
Disc herniation.
For some reason, Tracy, you keep lighting up, so you've attracted my attention. Give me a differential.
I don't know if you can hear my sound coming through, Jim, but I'm saying disc herniation.
Okay. All right. Yeah, I can hear. Okay. Where are we now? Ariel.
I wrote like an SI or muscular issue also.
You can have one of them. Which one do you want?
Muscular.
Okay. All right. Anybody got anything different? I assume somebody's got SIJ because you had 2 of them. Anybody got anything different?
I went with a hip joint hypomobility.
Okay. Anybody else? All right, then let's just clear up the hip joint thing first. Sorry, who was that?
That was me, Patrick.
Patrick, okay, mate. Do you mean the hip joint is the source of the pain or the cause of a problem?
I was thinking that the hip joint could be either stuck or hypomobile, becoming a source of the problem, and the glutes having kind of overwork. Okay, all right. So actually, that's still the etiology. In that case, this would be a muscle problem. So it would either be a glute strain and attenuation of the gluteus muscle,
or a probably a degenerative tear. Yeah. Ariel, I think you said muscle, didn't you?
Yep.
Okay. All right. Okay. Fine. Now, eliminate them. Somebody get rid of the disc herniation for me.
You could do a straight leg raise test.
Okay. Yeah, all right. Yep. Okay. What about the SI joint?
The Fortin sign?
Yeah, either one or both. Preferably both will be positive, objective and subject. Good. Hip joint. No, sorry, not the hip joint. The glute muscle.
If it has normal strength and it's pretty pain-free.
No, you're not eliminating it, you're trying to include it, and that's not always easy. A quick one, the whole point of this is to get rid of it quick. So a quick, highly sensitive test to say it's not the glute muscle. Different way of thinking, I know. But get rid of it, eliminate it as a possibility.
Maybe palpating it?
Anybody?
Maybe palpating it, Jim?
Yeah, palpation. Okay. So we can exclude them, and if we can't exclude them, then we can include them in as a possible differential. Yeah. Central and bilateral low back pain in a 68-year-old. Now, again, the first thing that crops into your mind for a hypothesis. Anybody not thinking central stenosis? No, again, it's available. Again, it's not necessarily a bad thing, but this is a heuristic. I've got an old man with low back pain across his back, central stenosis. That's what a heuristic is. It can work very well, or it can be a pain in the ass if it becomes a prejudice, really, if you don't let go of it when you should. So, differentials then. Let's see, John. Still there?
Wait, Jim, were you talking to me? I'm sorry, my office coordinator was talking to me
Yeah.
real quick. What was the question? I didn't quite hear that.
Okay, a differential diagnosis for 2 that is not stenosis, central stenosis.
You could say
Can't be wrong, mate. Can't be wrong.
spondylolisthesis potentially.
Okay, all right. Okay, where are we? Chris, another one?
Disc herniation.
Okay. Cervantes, Coralia. Did I get it right that time?
Almost. You're almost there.
Ah,
Carolia.
shit. I'm sorry, but you're Cervantes from this point on.
It's okay. You could call me Cervantes. I was gonna say that what we can add is cauda equina just to rule it out.
You need a pathology. That's the anatomy. What's the pathology?
Like a SIJ segmental dysfunction.
No, that's not going to cause a cauda equina problem. This is massive compression of the extension of the spinal cord. So a disc would do it, a tumor would do it, fractures would do it, any sort of growth impinging on that area might do it. So this is a fairly massive catastrophic injury. Okay, so let's say tumor, all right, neoplasm, cauda equina. Okay. All right, anybody got anything else?
Jim, how about like a kidney disorder, kidney infection or cancer
No,
there?
why not? So viscerogenic, excellent. Yep. All right, let's speed up a wee bit then. How about a fracture? He's 68. He could have a pathological fracture there. Yeah. So get rid of the spondy.
You could look at movement deficits with your spondy. You'd be
Sorry,
expecting to see a large extension deficit.
they're going to have that with central stenosis as well. This is the problem. Spondylolisthesis is a central stenosis. Actually, you can probably get rid of this one just from the history. As he had it before, he's 68 years old, so the chances of having, and there's no trauma. If those three things in place, the chance of this being the first episode of spondylolisthesis is pretty much zero. Okay, but there is something else you can do, and that's do a PA. If this is central stenosis, that segment and probably the other ones as well are going to feel stiff. If it's a spondylolisthesis, it's going to be something other than stiff. You're likely to elicit a lot of pain, and you're likely to get what is an abnormal infill, which you may not be able to classify. Okay. That one's not easy though, because it is a central stenosis. If he was younger, it'd be even more difficult. But if he's younger, you'll be thinking of degenerative central stenosis anyway. Disc herniation. Well, you want to get rid of that with a straight leg raise again, but you can't. And I should have brought this up last time. Why not? I could do a straight leg raise and have a good straight leg raise, and this can still be a disc herniation. How so?
A contained one, Jim.
Yes,
Contained
exactly.
disc.
Yeah, so it's a contained herniation. Now, the first one could be, is a good age for it. That could be a contained herniation. But the second one is a bit old for it. Very old for it, actually. But otherwise, yeah, the straight leg raise is good. It would almost certainly be a contained herniation because he doesn't really have leg pain, and neither did the first one, number one. Yeah. What else we got here? Cancer. Can you eliminate that?
There's a bump test basically in prone. You're going to load the kidneys up and see. I'm assuming it would be a pretty excruciating pain.
Oh, hang on.
We
You're
would
talking
call
about
it
kidney.
positive.
Sorry, you're talking about kidney, yeah?
Correct.
Okay, now I was talking about the one before that, cancer. But kidney, yeah, actually, as a percussion test, you put your hand over the kidney and give it a bit of a thump that way, and that can hurt a lot. If it doesn't hurt, though, you're going to make the diagnosis that this is viscerogenic, or at least a provisional diagnosis viscerogenic, by finding nothing else. Is that okay? So everything
Yes.
orthopedic will be negative. Mind you, he's 68-year-old, but let me put it a different way. He's going to have orthopedic stuff there anyway. But everything relevant that you find significant in your exam will not be present if this is viscerogenic. And it's unlikely to be extension problems over flexion problems. Is that okay? But cancers, visceral stuff, pretty much always exclusionary. We got no idea how to examine the abdomen. I don't know anyway. And certainly none of us are experts in it. Don't pretend to be. If the orthopedic stuff is showing up negative, that's enough for you to fire it back to the doctor and say, or at least to get a second opinion from another orthopedist and say, what the hell's going on? I don't know. Get it back to the doctor. Is that okay? But the kidney, you can do a percussion test. And that is not always painful. It depends on the exact pathology. But if this is something like kidney stones, that hurts. Right buttock pain in a 50-year-old. What's the time? Okay, look, I'll leave those last two for you because we're running out of time. Is that okay? So work your way through those last two. And if you remind me, we'll talk about it next week. That'll only take a couple of minutes to get through. Are you all right with an extra 15 minutes of video if I do those bias error corrections for you?
That sounds great, Jim.
Okay, all right. Okay, I will do that. You guys are doing really well. You're engaging well, and it makes it a lot more fun for all of us.
Yeah, they had a good weekend. They did a nice job
Yeah, good.
and skill wise. So I'll try and sort out and give you, so you know, direction going into the cervical module to plan. I'll also give some thought to things that we covered that may need just a little bit of reinforcement from lumbar. And I'll try and get you a little bit more specific prep stuff for the cervical.
I think there's
Maybe we
still a
can work
couple
on
of
that sort
videos they've got on the lumbar spine yet.
Yeah.
I'll see the lumbar spine out in the videos.
Okay.
Hi, guys.
Good.
Good day. Good day.
Thanks,
Bye.
Jim.
See ya.